I'm Zach McCallum, and I'm a professional sick person. Now, before you go, cool career, how do I get into that field? Hold up. The pay is terrible. You're on call 24/7, and it's brutal physically. Plus, there are a lot of non-reimbursable expenses, and your coworkers, well, many of them are gems, but a few are real duds, especially if you choose an esoteric branch of the field like mine, seronegative myasthenia gravis. I started training for this career before I'd even learned to talk, with asthma and the onset of a lifetime of frequent infections. The culprit turned out to be a primary immune deficiency. My bone marrow can't make certain antibodies, so it's infections galore. When puberty hit, I developed severe endometriosis. I was born female and tried, not always successfully, to live as a girl and then woman for the first 30-some years of my life. Once I accepted that I was transgender and went through transition, I was a lot happier. Does that have any bearing on my career in MG? Not really. Anyway, crippling endo is on my resume with indescribable pain, multiple surgeries, infertility, anemia, and finally a hysterectomy, and then transition, so I sort of saved myself a step there. I decided to ignore all that and become a graphic designer and computer user interface designer. I loved that career and would have happily stayed in it for life, but my medical problems put me in a bind. Change careers and become a professional sick person, i.e. go on disability, or else. Else was not a good choice. So I went on disability and reworked my life from the ground up. Became a writer, made new friends, transitioned to male, bought a house a block from the beach, got my best friend Ryan as a roommate. It wasn't the life I'd hoped for, but it turned out that you could be sick all the time and still be happy. And then the irresistible lure of a new specialization. By irresistible, I mean I had absolutely no choice. Myasthenia gravis. In 2013, my hands started to become painful and weak after use. I switched to bolo ties and slip-on shoes. I thought it was carpal tunnel. The tingling numbness in my pinkies was, for sure, and surgery fixed that. But the cramping weakness remained. And then I had a several-day period of severe blurry vision. That freaked me right out, and I went to the ER, where they told me it was a migraine. But I said, I've had plenty of migraines, and they all involved headaches, not blurry vision, and migraine meds didn't help. Migraine, they insisted. See an ophthalmologist, they said. By the time I did, the blurry vision had resolved. The doc said, I don't know, try artificial tears and let me know if it happens again. When it happened again a few months later, she said, maybe see a neurologist. But again, the episode had resolved by the time I got an appointment. So the neuro also said, dunno, call me if it happens again. By early 2015, I was having more problems. I couldn't get my legs into the car without lifting them by hand. My head was hard to hold up. Groceries were hard to carry. Stairs were hard to climb. But denial, it ain't just a river in Egypt, as they say. I figured I just needed to shape up. Maybe I needed to work out more. I got serious about going to the gym, even though it felt like torture and absolutely wiped me out. I was having hip, upper back, and shoulder pain with my weakness and fatigue, so I was diagnosed with fibromyalgia and sent to a pain management class. It wasn't supremely helpful. I complained about my problems in an online community of people with chronic illnesses, and one woman said, I know what's wrong with you. You have myasthenia gravis, like me. I rejected her suggestion out of hand. She was disabled, needed a power wheelchair, had bad vision all the time. Clearly that wasn't what was wrong with me. Except by November, I was using a cane. And even so, was having such a hard time walking, I had to ask a stranger to lend me her arm so I could get across a street. Ryan had to go behind me and help me lift each leg as I climbed the steps to our second-floor duplex. Getting groceries had become an exhausting ordeal that left me in bed for hours. I'd given up crusty bread and bagels, steaks, salads, even movie popcorn, because they were too hard to chew. I went back to the neurologist. This time, he tested me for MG and LIMS, but all my blood tests came back negative. And without antibodies, that's where you get into those not-so-awesome coworkers. Even though 10 to 15% of MGers are seronegative, there are a whole lot of doctors out there who just refuse to believe you can have MG without a positive blood test, and they seem dedicated to gaslighting their seronegative patients. It's created a tremendous amount of trauma in the seronegative MG community. Virtually all of us have some degree of defensive dread at the thought of having to interact with a new doctor. I'd like to ask some pointed questions about what medical schools are teaching their students that lead some doctors, especially some neurologists, to take such an adversarial position with their patients. But I'll save that for another soapbox. Anyway, he said no antibodies, so it's not MG. Meanwhile, the doctor I was seeing for fibromyalgia was so alarmed by my gait, he insisted I start using a walker and said he'd send a note to neurology. I went out with friends and had to lean against a wall and sip a shake while everyone else had lunch because I couldn't hold myself upright or manage solid food. At a Christmas party, despite having no alcohol, I ended up lying on the couch and slurring my words like I'd been drinking all night. I went back to the neurologist, who did a Tinsalon test. And wow, magic! As soon as the infusion was in my veins, I felt my body come back alive. But I didn't have droopy eyelids, so the neurologist couldn't see the difference. He could only rely on my report of how much stronger I felt. Could be a placebo effect, he said. Still, he gave me a trial of Mestinon, which was a miracle. 20 minutes after taking a dose, it was like a switch was turned on and my body starts working. And when it wears off, I'm a marionette with cut strings. Maybe it is MG, he said. You need to see the neuromuscular specialist. That was mid-December. The earliest appointment I could get was April. In the meantime, he put me on high-dose prednisone, which made me very worse very quickly, so we stopped that. In February, I surfed the edge of my first crisis. I was already weak, barely able to walk, and then suddenly I couldn't breathe. My roommate called an ambulance, the ER put me on BiPAP and sent me to ICU, and that plus IVIG turned it around after a few days. I went home weaker than I'd been before and started using forearm crutches all the time. When I finally saw the neuromuscular specialist in April, he did a repetitive nerve stimulation test, which showed a classic decrementing response, exactly what you'd expect to find in myasthenia gravis. Because of the immune deficiency, he didn't want to put me on any of the classic immune suppressants for MG, but with regular Mestinon, increased IVIG, PT and OT, and my forearm crutches, I was managing. Sort of. Meanwhile, it was clear that continuing to live in the San Francisco Bay Area in a second-floor walk-up was not going to work, financially or physically. After some dedicated searching, I landed in Portland, which met my major requirements for socially liberal, good international cuisine, access to university-level medicine, and real seasons that include autumn leaves and winter snow. In July 2016, I bought a house there with a master on the main floor and enough space and budget to make it wheelchair accessible. Ryan and I were set to move. August was for packing. Except I got really, really sick with another BiPAP level crisis and spent the month in the hospital. So that's how I got out of packing. Sorry, Ryan. On September 1st, he picked me up at the hospital and we headed north to meet the moving van. I promised I'd check in with my new medical team immediately, and I did. I was flat. That was when they said, "Yikes, son, you need a power wheelchair." I couldn't have agreed more. I had 3 hospitalizations for exacerbations that fall and winter, another one in May, one in September when smoke from fire season set off asthma, which set off MG, and that's been kind of my pattern ever since. A couple of week-long hospitalizations for MG a year, with the occasional several-week blowout. During a flare, my breathing gets bad enough I need BiPAP, but I haven't had to be intubated, though it's been a close call a few times. I get so weak I literally can't move and have to be turned and positioned by nurses. I can't chew and swallow anything more than a few bites of puree, and let me tell you, pureed eggs are nasty. If you get stuck on a puree diet, opt for mashed potatoes. IVIG usually turns it around for me, enough to go home after a week or 3. So there I was in Oregon. I joined the Portland area MGFA support group and several MG communities online, all of which were amazingly helpful. But I also had a new neurologist who sent me for new tests, and decided I couldn't really have MG because I was seronegative and I had a negative SFEMG. Now, I know it's the gold standard for MG diagnosis, but it has a 5% false negative rate, and I still had a positive RNS and absolutely classic MG symptoms and strong response to Mestinon and IVIG. He wasn't swayed. He halved my IVIG. I still needed some for the immune deficiency and threatened to take away my Mestinon. Predictably, my MG got worse. My asthma also got worse with another wildfire season, and I got put on a high-dose prednisone taper. And this time, after 3 days of steroids and entirely unexpectedly, my MG got better. Like, a lot better. And worse again when I finished the steroids 2 months later. That certainly made it seem like an autoimmune situation. When I heard from friends at the support group that a neurologist who was seronegative friendly had joined the HMO, I scheduled an appointment immediately. I prepped like crazy. I got a disc with my medical records from California and sorted through them to print out my RNS results and neurologist's notes. And that new doctor, bless him, said he'd never seen those records. Yep, they were not in my chart, despite previous doctor assuring me he'd read them. You have seronegative MG, he said. And just like that, I had a neurologist who had my back. I continued my semi-annual hospital trips for MG flares. We tried Cellcept for a year with no improvement, and then COVID hit. I spent February and part of March 2020 in the hospital for a particularly scary MG flare. When I came home with COVID looming, we decided to stop the Cellcept. The plan was to try rituximab, but before I could start that, I went hard on that professional sick person thing. I had a couple of rounds of bowel surgery with peritonitis and an emergency ostomy, each followed by complications and an MG flare of its own. The most recent, as I record this, was July 2021, followed by another MG nightmare and ICU stay, and I'm scheduled for more surgery to finally reverse the ileostomy. But that's just a side job. MG is still my main professional focus. My neurologist and I are still looking for more effective treatment. I'd really like to be able to go for a walk of more than 100 feet. I'd like to be able to leave my wheelchair behind and just run to the store like a normal person. I'd like to hike Oregon's beautiful trails and maybe even go camping again. I know this career history sounds maybe a little tragic, but I swear to you it's not. I'm not just a sick person. I'm a professional. I once founded and ran an endometriosis support group. So with that experience under my belt, I became an MGFA support group leader in Portland. I started writing for MyastheniaGravis.com. I joined the MGFA Patient Advisory Council. I'm doing my best to be a good educator, a good advocate, and to find meaning in my work as a professional sick person. And I'm happy. MG sucks, sure, but as I'd already learned, you can be sick all the time and still have a great life. My wheelchair lets me go places and do things I otherwise couldn't. I have wonderful friends, many of whom I've met through having MG. I can't go hiking, but I can take my wheelchair on paved trails. I love being a writer. I still make art, and I'm always learning. My life isn't what I thought it was going to be, but different isn't bad. And on the whole, my life is good. So don't take this career path unless you really have to. But if you do, you can definitely make it work.
Hello, my name is Daryl Lee. I am the Director of Finance at the MGFA. I would like to introduce Dr. Carolina Barnett Tapia. Dr. Barnett Tapia is an assistant professor at the Institute of Health Policy, Management, and Evaluation at University of Toronto in Canada. She serves as the co-chair of the steering committee for the 14th International Conference that the MGFA will be holding in May. Her research is focused on patient-centered outcomes in neuromuscular disorders, This includes how to capture the patient's perspective on their symptoms and activity limitations, as well as their preferences in terms of treatments. Dr. Barnett Tapia will give us a preview of the international conference today.
Hi, and thank you for inviting me to give you a short preview of the upcoming MGFA International Conference. My name is Carolina Barnett Tapia. I'm a neurologist at the University of Toronto. I'm one of the co-chairs for this meeting. So the MGFA International Conference is the premier global scientific conference that is focused on MG. So we do have multiple meetings that are from general neurology or neuromuscular disorders where we present research regarding myasthenia and myasthenic disorders. But this is the only meeting that's only focused on myasthenia gravis and related disorders. And the aim of the meeting is to present the latest science on MG and other disorders. We aim to get the scientific community and the clinical community together. And it's held for 5 years. So it's a very nice meeting because we have enough time between meeting and meeting to really have enough advances and new research coming out that we can discuss. The last meeting was held in 2017 in New York City. And as you can imagine, it's a very popular meeting for all of us who are researchers and clinicians in myasthenia and myasthenic disorders. So the date is May 10 to 12. It's going to be held in Miami, Florida. And if you're interested in registering, please go to www.myasthenia.org and you'll find instructions and the tentative schedule. Some new things for this year. We can't avoid the ongoing pandemic. So we do have some measures that are different than what you may have been used to in the past. Vaccines will be mandatory, as well as testing for people who are traveling as per the USA requirements. We will have a mask mandate within the venue. Speaking of the venue, we've changed to Miami for different reasons. We have a very nice setup, a large venue, so that will allow us to increase attendance and have more people coming, considering still social distancing. We are expecting increased global participation. And because of COVID, we will be having a virtual way of accessing the meeting. And we'll hope that that also will allow people from countries where traveling may be a little bit different to participate. We have expanded our clinical trials section, and I'm pleased to say this is because we have so many clinical trials and so much research in therapeutics coming out in myasthenia that we just had to make this a bigger part of the meeting for this year. Again, because we have so much research and too much content, a novelty this year is that we're having parallel sessions. That means we have 2 rooms running at the same time for one of the days, so we can split, hopefully by interests, and have 2 discussions at the same time. And we are quite interested in attracting and keeping young investigators and clinicians who are interested in myasthenia gravis. So we are having special meetings within the meeting to encourage these researchers and clinicians and to help them network and build a career in myasthenia gravis research. Another thing that is new is we partner with MGNET. For those who are not familiar with MGNET, is a NIH-funded network for myasthenia gravis studies, and MGNET will be hosting some sessions within the meeting, and they're also providing stipend for some of the people who have grants through them to come to the meeting. So all the preparation and all the work in organizing the meeting is truly a big collaborative effort. And these are the names on the steering committee. And a big thanks to everyone, because it's been a lot of extra time beyond everyone's normal activities. Just to give you a very sneak peek of what the schedule will look like, we have 3 full days. On the first day, I'm very happy to announce that Professor Angela Vincent from the University of Oxford in the UK will be giving us the keynote address regarding antibodies and the history of antibodies in myasthenia gravis. We have one of our clinical trial sessions, lots of focus on therapeutic development, new advances in the immunopathogenesis, in the understanding of the immunopathogenesis of MG, a session on autoantibodies, and the first poster session. On the second day, one of our parallel sessions, we're having a panel looking at international views of MG management. So we have aimed to have panelists from different, not just different countries, but different continents. And the idea is that they will be presenting cases that they've had locally. And our goal is to see how different healthcare systems and how different countries have different issues when treating people with myasthenia. So for instance, in some countries, there is no access to antibody testing. In some areas, certain medications may not be available or may be prohibitive in terms of cost for the majority of the population. So part of the idea is to share experiences and to also create a network of people in different countries where we can help each other and help the global community of people living with MG. On parallel with that, we'll be having a biomarker session, sessions on pathophysiology, updates in MG management. So we want to have a very clinical session, really focused on the clinicians, the people who treat myasthenia gravis, individuals, focused on especially in trainees and junior people. We'll be having talks on pediatric and congenital myasthenia, tolerance induction, of which I'm hoping to learn more during the meeting, but a very promising therapeutic area, and the second poster session. And on the third day, we will be having some platform presentations. So these are from all the submissions we have from the scientific session. We'll be highlighting the most interesting or promising research that will be presented, not just as posters, but as an oral presentation. We'll be having more clinical trials presented, and something that I think is becoming more and more important, we're going to have different views and discussions regarding the health economics of new treatments. As you know, new treatments are having really changing the landscape in myasthenia gravis, but new medications tend to be quite expensive, and implementation and access to care is something that is going to become one of the big discussions for us in the field, and we'll be having different perspectives of how to assess the cost and how to implement these treatments. We have a hot topic session, and MGNET will be having a training session about outcomes. So this is basically for centers who are running research projects to standardize the way we assess people with MG so that different centers in different studies are doing the same thing, and we can compare studies or within a study that, you know, different centers are doing the same thing. So you see a very packed schedule and lots of interesting themes. Just to give you a view, we have tried to make the meeting diverse. So we've been aiming of having a mixture of junior and more senior speakers presenting. We've been working hard to have gender balance, and we've been trying to at least represent different areas of the world. As you can see, we have North America, but we've been able to invite people from the rest of the world. You see, there's also blank spaces, so lots of work for us to do to reach out to people in different countries to speak in future meetings. So what's our update so far? We've had excellent response to our invitations to speak or attend the meeting, so there's lots of interest for people to come. We've received over 130 abstracts. We are currently reviewing, and the registration is ongoing. So these are excellent numbers, and we're very excited about the interest in the meeting. With all the abstracts of the people who submit their science and the presentations, we will be publishing this in Muscle and Nerve. For those who are not familiar, Muscle and Nerve is one of the main medical journals that publish research into nerve and muscle disorders, and myasthenia is one of them, and most clinicians in the field will read this journal. So we're interested in having the findings disseminated to the clinicians who will use them and the researchers who will use them in their practice. As I mentioned before, we will have a virtual component. So we will have a virtual option for people who cannot travel. And this is one for COVID, but also we're really hoping to be more inclusive and have more reach to people in countries that may not be able to normally come to the meeting. And with COVID, things change, week by week. So we are watching the pandemic closely. If we need to make any adjustments, we will do. But we have contingency plans, and we're really excited about having people coming to Miami. So in summary, we're all extremely excited to have the meeting. There are so many advances, and as I started reviewing abstracts, so much exciting science that's coming to the meeting. So we're very excited to share this with the MG community. I've been very fortunate to be working with a wonderful co-chair and steering committee, so really a major group effort. We've been dealing with the science and the speakers and the scientific session, but really all the MGFA team have been setting the meeting, going visit the hotel, and doing all the logistics that are several times more complicated with COVID. So really big thanks to all the MGFA people working behind the scenes. And finally, we will share the highlights from the meeting with the patient community. So for patients, sometimes scientific sessions can be a little bit too focused on scientific lingo, but we will be sharing highlights to disseminate this to the community. So I hope to see as many of you as possible in May, and thank you for listening.
Hi, everybody. Drea Carboni here. I'm an MG patient, a team captain, and the volunteer chair for the Coast to Coast MG Walk 2022. Save the date, November 12th, 2022, we have our Walk Where You Are celebration. We want to entice your competitive spirit with some East Coast versus West Coast competitions. So stay tuned for more information, and you can register today at mgwalk.org. See you there. Hi, everybody. Drea Carboni here. I'm an